Prostate general, the first are going to be the Roche equations, which calculate both lymph node risk, seminal vesicle invasion, and extracapsular extension. Lymph node risk is Gleason score minus 6 times 10 plus 2/3 of the PSA. Lymph node risk is Gleason score minus 6 times 10 plus 2/3 of the PSA. Seminal vesicle invasion is Gleason score minus 6 times 10 plus the PSA. It's the exact same thing, just take out the 2/3. Seminal vesicle invasion, again, Gleason score minus 6 times 10 plus the PSA. Extracapsular extension, Gleason score minus 3 times 10 plus 3/2 of the PSA. Extracapsular extension, Gleason score minus 3 times 10 plus 3/2 of the PSA. Your MRI of your prostate will generally be done in a T2 sequence. The central zone here will be dark. The peripheral zone will be even darker than the central zone. Your capsule of the prostate will be black. Your seminal vesicles back here will be white. MR spectroscopy is used only to evaluate the prostate, not the seminal vesicles. A normal MR spectroscopy will show high choline and low citrate. Cancer will show low choline and high citrate. The GU diaphragm is where the shape goes from slits to an hourglass shape. Just in terms of the anatomy, remember that your transitional zones here are where BPH nodules are located. Your peripheral zone is where cancer is most commonly found. Lymph node drainage, you have first, second, and third echelons. Your first echelon of drainage are your periprostatic and obturator nodes. I remember this through PO. Periprostatic and obturator. First echelon, periprostatic and obturator. Second echelon are going to be PEPI. These are your standing for the P's. So pre-sciatic, external iliac, pre-sacral, internal iliac. Again, second echelon, PEPI, pre-sciatic, external iliac, pre-sacral, internal iliac. Your third echelon are your M1A nodes. These are RIC, retroperitoneal, I for inguinal, and C for common iliac, REC, retroperitoneal, inguinal, common iliac. One more time. First echelon, periprostatic obturator, PO. Second echelon, PEPI, pre-sciatic, external iliac, pre-sacral, internal iliac. Third echelon, M1A, RIC, retroperitoneal, inguinal, common iliac. PSA density is your PSA value divided by the volume of the prostate. Normal would be 0.10 nanograms per milliliter squared. The volume of the prostate is usually 25 cubic centimeters. In terms of grade grouping, it goes from grade group 1 to grade group 5. Grade group 1 starts at Gleason 6 or less. Grade group 2 is Gleason 3 plus 4 equals 7. Grade group 3 is the linchpin. It's Gleason 4 plus 3 equals 7. Grade group 4 is Gleason 8, and grade group 5 is Gleason 9 or 10. One more time. Grade group 1, Gleason 6 or less. Grade group 2, Gleason 3 plus 4 equals 7. Grade group 3, grade group 3, grade group 3 is the linchpin. Gleason 4 plus 3 equals 7. Grade group 4 is Gleason 8, just think of that divided by 2, and grade group 5 is Gleason 9 or 10. ADT mechanisms. GnRH agonists include Lupron and goserelin. Lupron, the dose is 7.5 milligrams for 1 month, 22.5 milligrams for 3 months, and 45 milligrams for 6 months. Goserelin is also known as Zoladex. Non-steroidal anti-androgens, which block the androgen receptor. The main one you need to know is bicalutamide or Casodex. 5-alpha reductase inhibitors block the conversion of testosterone to dihydrotestosterone, and they help prevent the testosterone flare. Some practitioners will give bicalutamide for 2 weeks prior to initiation of Lupron to reduce the risk of potential flare from subclinical metastases and high-risk prostate cancer. Side effects generally from ADT include hot flashes, weight gain, decreased libido, decreased muscle mass, osteoporosis, which will require calcium and vitamin D supplementation. And if they're on long-term ADT, you should probably get a DEXA scan, and gynecomastia. With bicalutamide especially, there's a 15% risk with 50 milligrams plus Lupron and a 70% risk with 150 milligrams for 2 years. This image here shows both the sagittal and coronal views of the prostate. Just be aware of the fact that the central zone basically only surrounds the ejaculatory ducts, and that the apex of the prostate is essentially what is more caudal, and the base of the prostate is cephalad. You have the bladder, the urethra, the transitional zone, which surrounds the urethra, the central zone, which surrounds the ejaculatory ducts, the anterior fibromuscular stroma, and the peripheral zone, which is where the majority of the cancer is located. This image also shows that well. only in this case you're looking at a different sagittal section. Let's talk a little bit about workup for prostate cancer. You want to get a history. Ask about your AUA score. Lower score means better function. The max AUA score is 35. This is scored from 0 to 5 for each category, which is new FUSH. New is nocturia. E is emptying. W equals weak stream. F is frequency. U is urgency. S is straining. H is hesitancy. Again, each one of these is scored from 0 to 5. If there is a higher score, that means worse AUA function. A lower score is better function. Erectile dysfunction is scored via the 2EF or SHIM score. This is 5 questions. A higher score on the SHIM score means better erectile function. The max score is 25. So again, AUA, decreased score is better function, max score of 35, which is very bad. Each category of new FUSH is scored 0 to 5. ED, SHIM score is 5 questions. A higher score is better erectile function, max is 25. Also in the history, ask about prior TERP, history of inflammatory bowel disease, family history of cancer. Physical exam, the main thing you want to look for is digital rectal examination. Labs, you want to get a PSA. There are certain parameters in the PSA that are concerning for cancer. The PSA density, which we again described as the PSA divided by the volume of the prostate. Normal is 0.1 nanograms per milliliter. Anything greater than 0.15 nanograms per milliliter per gram is concerning for cancer. Your free PSA to total PSA, if it's less than 7%, is concerning for cancer, and then PSA velocity. If it's greater than 2 nanograms per milliliter per year, that's concerning for cancer. So one last time, PSA parameters concerning for cancer are a PSA density of greater than 0.15, a free to total PSA ratio of less than 7%, and a PSA velocity of greater than 2 nanograms per milliliter per year. Other labs include CBC, CMP, and LFTs, testosterone, genetic testing. Per NCCN, any patient that has metastatic disease, any patient with node-positive disease, very high risk or high-risk disease, or any pertinent family history should get genetic testing. There's also a role for genomic profiling with Decipher scores. This may be helpful to determine who needs ADT for intermediate risk disease. In terms of biopsy, you want a transrectal ultrasound-guided biopsy or an MRI-guided biopsy with 12 cores. Imaging, CT abdomen and pelvis if you have unfavorable intermediate risk disease or higher, or an MRI if you have positive lymph node risk of greater than 10%. Almost all patients get the MRI nowadays regardless. In terms of endorectal coil MRI, a 1.5 Tesla MRI gets an endorectal coil. A 3 Tesla can have or can also not have the endorectal coil. You want to get a multiparametric MRI with contrast. Again, most patients will have this either to confirm early stage disease or further characterize advanced stage disease. Tumor appears T2 sequence hypointense, meaning that it's dark on the T2. It's usually within the peripheral zone due to increased cellular texture. So the T2 sequence, the cancer will appear hypointense, meaning it will appear dark, usually within the normally high signal peripheral zone due to increased cellular texture. Again, T2 sequence, cancer appears hypointense. It's usually found in the peripheral zone where it will show up dark in an otherwise high signal area. It enhances with T1 with contrast. It is bright on diffusion weighted imaging. Dynamic contrast enhancement and MR SPECT also have characteristic findings. This image here is a good T2 sequence. T2 notice the marrow enhancement. Anatomic prostate zones appear as the following. This red here is obviously your peripheral zone. The largest glandular component that has a high signal T2 intensity, which is bright, as you can see here. The nodule is located here on the left portion of the prostate because it is dark. The central zone is a flattened cone-shaped zone of the prostate around the ejaculatory ducts, best seen at the base with low T2 signal. Again, the base is located more cephalad on the prostate. Transitional zone are your 2 lobes around the urethra. They have low signal on T2. BPH nodules will also appear here, so do not be fooled. The transitional zone is green. The anterior fibromuscular stroma is the anterior non-glandular tissue. It has a very low T2 signal. And then the periurethral zone has high T2 signal centrally, surrounded by lower signal intensity representing periurethral tissue and muscles. DWI sequence is diffused weighted imaging. ADC is the apparent diffusion coefficient value on the DWI. Cancer typically shows restricted diffusion, which will make it appear bright on diffusion-weighted imaging. Again, DWI, ADC is the apparent diffusion coefficient value on DWI. Cancer shows restricted diffusion, which will make it appear bright on DWI. A combination of imaging findings on the T2 weighted sequence, the DWI, and the dynamic contrast enhancement predicts the probability of cancer that is clinically significant, which is defined by the presence of any of the following: a Gleason score of greater than or equal to 7, including 3+4 with prominent but not predominant Gleason 4 component, a volume of greater than 0.5 milliliters, any extra prostatic extension. Each lesion is assigned a score from 1 to 5, indicating the likelihood of clinically relevant and significant cancer. PIRADS 1 is very low, meaning the clinically significant cancer is highly unlikely to be present. PIRADS 2 is low. Clinically significant cancer is unlikely to be present. PIRADS 3 is intermediate. The presence of clinically significant cancer is equivocal. PIRADS 4 is is just high, meaning clinically significant cancer is likely to be present. PIRADS 5 is the very high. Clinically significant cancer is highly likely to be present. PIRADS X is component of exam is technically inadequate or not performed. Technetium 99 bone scan is indicated for unfavorable intermediate risk or higher, and it's usually negative if the PSA is less than 10. Other things you want to work up are colonoscopy. Let's talk about staging per NCCN. Very low risk is the same as low risk, but only with T1C disease. You have less than 3 cores that are positive and less than or equal to 50% of cancer in each core. Also a PSA density of less than 0.15 nanograms per milliliter per gram. I remember this by less than 3, 5.0, and 0.15. That's very low risk, so the patient can jive. Again, less than 3 cores, less than or equal to 50% cancer in each core, and 0.15 nanograms per milliliter per gram. That's very low risk, so the patient can jive. Low-risk disease is Gleason 6, PSA less than 10, and T1A to T2A, which means up to less than or equal to 1/2 of one lobe. Think area code 610 for Gleason less than 6 and PSA less than 10, and then up to T2A disease. Intermediate risk disease is Gleason 7, a PSA of 10 to 20, T2B or T2C. T2B is greater than 1/2 of one lobe. T2C is both lobes. You can then divide intermediate risk into favorable and unfavorable intermediate risk. Favorable is one intermediate risk factor, meaning either Gleason 7, PSA 10 to 20, T2B or T2C, less than 50% biopsy cores, or Gleason 3+4. Unfavorable intermediate risk is greater than one intermediate risk factor as above. Again, Gleason 7, PSA 10 to 20, T2B or T2C. Greater than or equal to 50% biopsy cores positive. Gleason 4+3 disease. Specifically, they will ask you grade group 3. Again, remember, grade group 3 is the linchpin. This is the earliest prostate cancer stage where nuclear medicine bone scan is indicated. High-risk disease is Gleason 8 to 10, PSA greater than 20, T3A, meaning extracapsular extension, to T4, which is invades adjacent structures. Let's go through the T staging. T1A is an incidental finding in the prostate less than or equal to 5% of the tissue. T1B is an incidental finding in the prostate greater than 5% of the tissue. T1C is identification because of increased PSA. T2A is less than or equal to 1/2 of one lobe. T2B is greater than 1/2 of one lobe. T2C is both lobes. T3A is extracapsular extension. E comes before S. T3B is seminal vesicle invasion. T4 is fixed or invades adjacent structures. Lastly, very high risk, T3B to T4 or primary Gleason score 5 or greater than 4 cores with Gleason 4+4 or higher. In terms of kind of stage grouping, stage 1 is T1, T2A. Stage group 2 is T2B, T2C. Stage group 3 is T3 or T4. Stage group 4 is node positive or METS, is going to be the basic way that I remember that. Let's talk about prevention, screening, and no treatment. Screening, the greatest benefit appears to be in men ages 55 to 69. Again, 55 to 69. U.S. Preventative Task Force says discuss screening with men age 55 to 69. NCCN says age 45 to 75 are candidates. PSA greater than 1, repeat every 1 to 2 years. If less than 1, repeat every 2 to 4 years. You want a biopsy with any PSA greater than 3. The AUA also suggests age 55 to 69 for screening. Screening trials include PLCO, the U.S. Andriol et al., Journal National Cancer Institute 2012. This is plus or minus annual PSA times 6 years. There was no difference in prostate-specific survival at 13 years. The other is ERSPC, European Schroeder, Lancet 2014. Again, plus or minus annual PSA times 4 years. In this trial, the European trial, screening reduced death by 20%, but there was a high rate of overdiagnosis. 1 prostate cancer death was avoided for every 781 men that were screened. Again, the greatest benefit appears to be in men age 55 to 69. U.S. Preventative Task Force says discuss screening with 55 to 69. NCCN says age 45 to 75. PSA greater than 1, repeat every 1 to 2 years. If less than 1, you can do screening every 2 to 4 years. Biopsy with any PSA greater than 3. And AUA also suggests 55 to 69. What about the role of watchful waiting? Radical prostatectomy versus watchful waiting. Scandinavian SPCG4, Bill Axelson's trial. This is published in New England Journal of Medicine in 2014. This is about 700 prostate cancer patients under the age of 75. They had T1 to T2 disease. They were operable. They had a life expectancy of greater than 10 years and a PSA of less than 50 with a negative bone scan. They either got watchful waiting or radical prostatectomy. ADT was started for symptomatic local progression or distant disease at 29-year follow-up. Overall survival benefit of 2.9 years with radical prostatectomy. Extracapsular extension and Gleason 7 were highly increased for the risk of death. Reduced mortality with surgery with 23-year follow-up. This benefit is largest in men less than 65 years of age. In terms of the PIVOT trial by Wilt, NEJM 2012, 740 patients, CT1 to T2, NX, PSA less than 50, age less than 75 with a negative bone scan, life expectancy also greater than 10 years, 40% low risk, 33% medium risk, 22% high risk, either got watchful waiting or radical prostatectomy, no difference in overall survival or prostate cancer-specific survival. There's a trend to benefit in overall survival with surgery over observation, especially in those with intermediate risk disease. Surgery leads to notable adverse events, notable urinary, erectile, and sexual dysfunction. What about prevention? Finasteride 5 milligrams daily times 7 years decreases the risk of prostate cancer 25 to 18%, but it is generally a higher grade when diagnosed. Prophylaxis of gynecomastia, radiation to the nipple areolar complex, 4 grade times 3 with 6 to 9 MeV electrons to the 90% isodose line. The treatment of gynecomastia can include tamoxifen, 20 to 50 milligrams times 6 months, surgery or radiation, which can decrease the pain but not the actual tissue. For patients treated with ADT, you can check testosterone levels with PSA. Once the testosterone is back at the normal level, you can then trust the PSA again. Let's talk more about toxicity. Robotic radical prostatectomy. The rates of erectile dysfunction at 1 year are 50%. Incontinence is 15 to 20%, and frank incontinence is seen with 5% of patients. External beam, let's break it down into GU toxicities first. Acute, grade 2 is 20 to 30%, and grade 3 is less than 5%. Late grade 2 GU toxicity is 10 to 15%, which is usually urethritis requiring medication. Grade 3 is 1 to 2% and is usually urethral stricture. GI toxicity, acute grade 2 is 30 to 40%, and grade 3 is less than 5%. Late grade 2 GI toxicity is 5 to 10%. It's usually bleeding. And grade 3 GI toxicity that's late is less than 1%. Bleeding requiring transfusions or laser cauterization. Erectile dysfunction late is 30 to 50%. It depends on the age and pretreatment function. Greater than 90% will have reduced ejaculate with external beam. Secondary malignancies, 1 out of 300 at 10 to 15 years. Toxicity treatments we can go through. Urinary frequency, give Flomax 0.5 milligrams QHS or another alpha blocker. Dysuria, Pyridium 200 milligrams by mouth every 4 times daily. Ibuprofen 300 milligrams up to TID. Oxybutynin 5 to 10 milligrams by mouth daily. For erectile dysfunction, sildenafil or Viagra, 60 to 70% of patients will have improvement, or tadalafil Cialis. For diarrhea, you can use Imodium or Lamodal. Hot flashes, venlafaxine, black cohosh, has a 50% efficacy in Megace, but you're concerned about weight gain. Rectal bleeding, Carafate enemas, 2 grams per 20 mils BID. Argon plasma coagulation, or hyperbaric oxygen, 30 sessions Monday through Friday. There is retinal and lung toxicity with this. Urinary bleeding, do a UA, cytology, and cystoscopy. Pentosan polysulfate, 100 milligrams TID, and hyperbaric oxygen. Follow-up after initial definitive treatment. You want to get a PSA every 6 months or every 3 months if they're high risk for 5 years. Note that it can take 3 years to reach the PSA nadir. Definition of failure after EBRT is Phoenix definition, which is the nadir plus 2 nanograms per milliliter. You want to get a DRE annually. You can omit this if the PSA is undetectable. If they have biochemically recurrent disease after radiation, which again is the nadir plus 2, it can take 3 years to get to the nadir workup. Prostate-specific antigen, doubling time, transrectal ultrasound guided biopsy, bone scan. Sodium fluoride is more sensitive and less specific than a bone scan. You can get a bone scan if that is negative. CT and or MRI, fluciclovine PET or PSMA PET would probably be recommended now. If the patient was originally T1 to T2 N0 and the current PSA is less than 10 and life expectancy is greater than 10 years and local disease only, then you can do local treatment with radical prostatectomy, brachytherapy or cryotherapy, or observation. If none of the above or local biopsy is negative, then do intermittent ADT, GnRH agonist, 8-month cycles. If PSA is less than 4, at the end of the cycle, stop until PSA is greater than 10 or clinical progression, then restart. Radiation in the setting of metastases, 8 times 1, 6 times 4, 4 times 5, 3 times 10. Radium-223 is an alpha emitter, improves overall survival in castrate-resistant prostate cancer with bone mets. Grade 3 heme toxicity is less than 5%. Strontium or samarium are beta emitters, the improved symptoms only. Oligomets, SBRT in a clinical trial, 50 to 55 gray and 20 fractions to the prostate primary, improves freedom from progression, but not overall survival for all comers. The low burden of metastases from Stampede does have an overall survival benefit, but only the low burden group. For castrate-naive prostate cancer, that's M0, this says ADT. Castrate-naive prostate cancer, M1, ADT plus abiraterone plus prednisone improves overall survival per Stampede. Castrate-resistant, or M0, says enzalutamide or apalutamide plus those for M1 below. For castrate-resistant M1, says ADT, keep testosterone less than 50, abiraterone plus prednisone or methylprednisone, enzalutamide or apalutamide, ketoconazole, Casodex, docetaxel and steroids, cabazitaxel, Sapula CLT, pembrolizumab if microsatellite and stable. Let's just go through the prostate anatomy here again. So you have your seminal vesicles here. We're looking at a sagittal section. This pink is the peripheral zone. So you'll notice it becomes much more apparent as you go from the base of the prostate to the apex. The central zone is mainly surrounding the ejaculatory ducts. The anterior fibromuscular stroma is this blue here. The transitional zone is kind of in gold. Again, this is going from the base, where the central zone is quite notable, down to the apex, where really the peripheral zone takes over, and this golden area is the transitional zone. This shows extracapsular extension of prostate cancer on various sequences. This is T1 weighted imaging. This is T2 weighted imaging in sequence B here. This is dynamic contrast enhanced magnetic resonance imaging, and this is diffusion weighted imaging.